Yeah, it's amazing to see how far MIS has come in the last 20 or 25 years. It's great to see you guys doing it, everyone getting into it, and the technologies that's enhancing it. I'm going to literally talk of principles. I think you guys have heard me enough. I'm literally going to talk of principles that got me to where I am, and then why I do what I do and show you execute it. And I think the principles matter. They really matter why we are doing what we are doing, and hopefully start making sense over time. So to me, it's not about lateral or oblique. I don't care where you put your incision. It's about finding the front of the psoas. It's about being pre-psoas and not going through the muscle. Now, if you put it in front, it's a little easier to get in front of the psoas. That's all it is. It's not about the approach. There's so much noise being made about it. I can get you in front of the psoas through a direct lateral approach. So the first thing is getting in front of the psoas. Two is about directly seeing where you are before you dock. I think that's critical. We've just lost the basis of science. We have to see where we are, dock where we are, and make sure there's nothing in your way when you put that down. That's critical. Three is identify the anterior border of the psoas. It is clear as daylight if you see it. There's a nice tendon called the psoas minor tendon that lies anterior and ventral to the psoas. It's just tucked underneath. It's this big tendon. A lot of people think it's a nerve. It's not. Hopefully in the anatomy lab, we can show it. 85% of them have it. Yes, 55% do not. Four, I never retract the psoas. There's no reason to retract. In we did thoracic abdominal surgery for years. We never retracted, we rolled it. I think someone talked about it. It rolls. It's not attached anteriorly. Anatomically, it's only attached to the transverse processes and the posterior part of the body. It floats on the top. You can lift and roll it, so you never have to retract it. Five, don't dissect or mobilize the vessels. There's no need to. There's no need to move it. We do not dissect the carotid and ACDF. It moves. These are structures that move. You create that plane. There's an areolar plane right between the psoas and the aorta every single time. It's a clean plane. And as a surgeon, just create that areolar plane. It moves. Structures move around. So measuring of a static MRI has never made sense to me. I'll go back and back on this. You put your finger and you move it. You create the plane with your fingers. So it's all about the anatomy. It's not about jumping, and you'll see it every single time. Hopefully we can show this, and it'll happen every single time. The key for me lateral, though, is when you go this way, you can do 5-1 at the same time. That is the biggest advantage. I think my patients, most of them need 5-1. Now, we don't need a different story, but this is the only approach that gives you 5-1 at the same time. You can do 5-1 every single lateral interbody level, all the way thoracic. You can go where you want to go. And we've gone as much as we need to go depending on the deformity. So in one position, you can manipulate the entire anterior column through a lateral approach from 5-1 working you up. So that, again, is a big key for me, where I can manipulate the anterior column. And yes, anterior column manipulation really matters in deformity. And lastly, if you want to do an ALL release, you're staring at it. If you're going oblique, actually staring at the ALL every single time and makes it easy, but it's so rare for me to do it. Maybe now it's 1 in 2 years. Extremely rare. We don't do it at all except in these two indications. It was a 4-to-1 fusion if you want to get a 3-4 instead of a PSO, or you got a 3-to-1 fusion and get 2-3 depending on the deformity. I can probably get 1 in 2 years. No, don't do it at all. We're talking of big deformities, and the next principle for me, if I'm going to approach this MIS, it's not about the numbers. It's about the anatomy, and segmental anatomy at each and every segment that I'm going to attack. If I'm going to do a lateral at that segment, I want to know what 4-5 is, what 3-4 is, what 2-3 is, what's the anatomy around it, how am I going to get my laterals, how am I going to do my things without an osteotomy. So studying segmental anatomy at each single level, right? And with all these deformities, all these we've done. That's why you get all these tests. Nima talked about it really well. Everyone gets all these, and he talked about this. Nima really went beautifully through the whole thing. But I very strongly encourage anyone trying to get into this field, read it. It's not a scoring system, it's a checklist. So you know if someone's got this, you're going to run in trouble. Call somebody. Have somebody experienced next to you doing it. Understand what you're looking at. And that was the biggest reason we put this. In fact, a lot of young surgeons actually came to me, asked me, please, we need to get something. What is hard? And I think it does. And you go through it, look through it. Nima, I think, went in really good form with it. The MRI for me will come in a minute. It's about the bifurcation of the vessels. I'm going to come back to it a lot. How important that is in the anatomy and how you decide what to do, and how we decide what you do. How we get there? CT is extremely important. That's what I was going to tell you. It's fused or not. Rigid and stiff is meaningless to me today. Meaningless. I don't even know what that means anymore. You can move the spine if the facet is not fused. Now the segment is not fused. You can mobilize it if it's not fused. So in CT scan, I'll tell you the facet is fused or not, or do you have interbody fusion. If you're bridging osteophytes, this came up in college last week. And honestly, I was trying to answer, if you're bridging osteophyte, you can break it. You routinely break it with an osteotome. But you have an interbody fusion, you can't. So that segment is not going to get a lateral procedure or an interbody procedure. You then work above or below and try to see what are you going to do. So segment by segment, you analyze it. This was missed, by the way, on X-ray and MRI. And a bending film is useless in those patients I show you. It hurts, they don't bend. So all of them are stiff and rigid by definition. And you know nothing till you look at the CT scan. And you don't need an osteotomy if you studied the anatomy of each segment individually. And then last is bone density, really important. And I think we've shown that parathyroid hormone analogs are really useful. 85% increases. I've been using it for more than 13 years now. And I have very serious doubts, I'll say it right here, about the efficacy of Evinity in this setting. Evinity is a sclerostin inhibitor. It stops the osteoclast. We're doing spine fusion. It's a really big issue. That's a different topic. You need a parathyroid hormone analog with your fusion if you're going to start tackling these people. So be careful about that. We talked about transperitoneal. So basically, you're entering the plane between the aorta and the psoas. This plane is so big, it's 5 times the size of that plane which we do every single day. I haven't seen a paper to this day, anyone measuring the distance of the carotid from the trachea and the esophagus. We would not operate. None of us would do surgery anymore because it's barely 2 millimeters. Yet every single day we do that, and we do it really well. Why? We just create a plane and go down. It's the same thing here. It's 5 times the size. So if you look at the bifurcation, it's critical, right? And I'll tell you why it's critical. You're deciding whether you want to go in between the vessels as an ALIF, or you're deciding to go lateral to the vessel as a lateral. So the bifurcation matters. This one clean, you can go lateral to the aorta, right? If you go back to that 3-4, there's a lot of room, no problem. That psoas will move, and the aorta will move. If you go here now, 4-5, it started to split. What the split is not critical is where the IVC is coming. The IVC splits and sneaks under the aorta. That looks fine, but go 1 millimeter down, it's already sneaked down. This would be a disaster in any lateral approach you did. It's got nothing to do with highlighting psoas, nothing to do with iliac crest, nothing. Why again? The vessel bifurcation is directly, embryologically, segmentally related to where the crest lies, where the psoas goes. That means if it's bifurcated high at 3-4, your 4-5 is segmentally a 5-1 already. It is a segmentation issue. So if you look at the vessel, you'll know where it is. And all those issues go out of track. So you do an ALIF in that setting. If you're in this setting there, do an ALIF even at 4-5 in the lateral position. Obviously, 5-1 is almost behaving as 1-2. But on the flip side, there's 3-4, 4-5, and 5-1. I can go lateral to the vessel that hasn't bifurcated. So this is more like a lumbarization. So the vessel goes directly with the psoas. Please go look at it every single time you look at the MRI. It's an embryological segmental event. They go together. Again, if it's bifurcated, psoas will be high, crest will be high. So you don't need to look at all that. So that's why you look at the vessel every single level to plan what I'm doing, ALIF between the vessels or lateral to it. So that makes it easy now. This is the approach. When you're doing a 5-1 approach, I think it's critical. Is there a pointer here? There. This is really critical. That is where the disc is lining up in the body. And this you just draw a straight line because the incision is in the middle. And you take it lower down. Here's the ASIS. I should have marked it out. You want to go well somewhere between the middle of the ASIS and the abdomen. I used to go closer here, but don't. The lateral femoral cutaneous nerve comes right here. You're much better off going down. Also, it makes it easy to go orthogonal into the disc. The problem is you got to come in this line, remember, if you're going to do it. So what's the drapes? You need to be there to drape. They will shut you off. There's no way you can get in here unless you keep that angle to get in if you're going to do this. You will close yourself off. So this is important. Always tape it so you can work this line to get your disc in this way. But this is more for the access to get in there. And then 3, 4, 4, 5 usually go, depending on how big the patient is, just anterior to the disc. We don't even mark this. I just mark the anterior part, the navigation floor or whatever. And that's 1, 2, 2, 3 for us routinely. And I'm going to run, that's a 5-1 exposure. It's basically the oblique exposure. There's ASIS. I think you can see somewhere there. There was an ASIS up there. I'm just going to run just lateral to the rectus sheath. You go down there, and you sort of move your plane down, and you'll see it as it develops itself. It's very clean. Go into the retroperitoneal space. You let that develop there, and you again find yourself with your finger. And you learn with general surgeons, finger dissection is critical. You're almost like a general surgeon when you're doing this. Use your finger a lot. In fact, we don't need, the bovie, this is where the bovie stops. There's no bovie after this, once you cut that. In lateral approach, I don't even use the bovie there. It's all finger, finger, finger. Your finger cannot damage anything. It's a very easy instrument to use, and you go down, slide it, that's the retroperitoneal fat coming in. Now it's all finger dissection, going to retroperitoneal space, sweeping everything away from the lateral aspect down to the central. So you reach up under the iliac crest and just sweep everything down. So you got it down, you move it away, and you'll feel the psoas, you'll feel the vessels, and once you do that, you then see the ureter. The ureter should move with the peritoneal fold as it moves. It always moves, you can always see it there. Once you get in there, then go to the next one, you expose it. If you plan this right, you just need 3 retractors. 1 on the left internal iliac, in the bifurcation, 2 on the right internal iliac. The only thing you ever take is the middle sacral. You're not mobilizing one single thing. There's no reason to if you planned it on the MRI. That, to me, is what MIS is about. If you're going to start mobilizing vessels, it's not MIS. I'm sorry. You move something. It's about muscle preservation, tissue preservation, stay where you are. So we develop these approaches where they go. It's not about how easy it is, but what we can do best for the patient. So anyway, you can just see I just did that. After this, it becomes an ALIF. The only problem is you're looking horizontally at the patient. You're doing your disc prep this way. It takes about a case or 2 to get used to it, and you start lining yourself up. You're not sure, take some AP and laterals, and make sure I use navigation to get your trajectories right. And this is like an ALIF as you routinely do every single day, except you're going horizontal now. And you're lining yourself up along the line with disc, and then you just do your ALIF. Obviously, keep your end plates intact. There's your ALIF there, and then you can put your prosthesis in. And the prosthesis for me today is pretty much, usually I use PEEK with retaining screws. I don't use this plate anymore. But the plate actually stopped me from getting the prosthesis where I wanted to go. So I stopped doing that. I just use integrated screws today, a prosthesis with integrated screws. Anyway, so that's for 5-1, right? And then if you're doing multiple levels, you already got the opening at 5-1 if he did it before. That's the other big efficient part of what happened in lateral approach. Our guy's extremely busy. Our vascular surgeon, I use him only for 5-1. Sometimes he's not there. I start 4-5-3, 4-2-3. Whenever he shows up, he comes and does 5-1. If he comes first, he does 5-1 first. So I get a window somewhere between 8 to 11, pretty much where he can come around doing 5 levels. So that's worked very efficient for me. But you have this open, and you put your finger in. You're in the retroperitoneal space. You already cleared it. You can feel the psoas. Clean all that out. Go through the abdominal wall. Drop your probe. You're right there. You can feel the front of the psoas. Actually, it makes it easier if he's already done it. If he's not, and you're doing a de novo 3-4-4-5, that's what this video is. But sometimes you can get 2-3-2, but 3-4 and 4-5 every single time. Simple, small, 1-inch incision. Drop through it. Once you get to the external oblique, literally once you see it, it's all finger after that. I'm going to let this run a bit. It truly is an anatomical approach. And this, I think, most of you know. See that snake? Once I see that thing, that's it. I never use any snaps, no mets, no and bombs, no dissectors, nothing. It's finger, finger, finger. Your external oblique will split. Your internal oblique rises obviously perpendicular to it, which is right inside. It splits. This is all just to show you there's internal oblique being split vertically now. Next, you'll see the transversalis below. And once you see that, you poke right through it and always feel the inside of the iliac crest. How many times I've seen fingers floating in subcutaneous? If you can't feel the inside of the iliac crest, you're not in. In a very obese patient, it's very easy. You're out. Once you then that sweep, obviously, that's all we know. This to me is critical. This step right here, right? I'm going to stop you. My finger, in most patients, you can feel the aorta, just like you feel the carotid. I know where it is. My finger's sitting there. I'm just sliding my retractor right over it. Now, in a very big patient, you may not. But the aorta is going nowhere. That thing doesn't fly around. It's where it is. If you planned it, you know where it is. It's right there. And you just put your retractor down. So thin retractor goes down there. So now that goes in, right? Oh, let me go back. Sorry. Let me go this way. So that goes down there, right? So once you get that retractor in, let me get that here. The next retractor is critical. That retractor, the second one, is going over the psoas. So if I can play that, play there. That goes over the psoas and not pulling it. There's no reason to. I want to see the psoas. So the moment you do this, you'll start seeing the psoas. And if you're on the right spot, which usually just in front, you'll start seeing the anterior border of the psoas. And I hopefully can show you that. There's usually some fat. You can use a sponge stick, sweep the fat away. You'll see there. Let this run. You can start seeing the front of the psoas right there. There is nothing else there anatomically. If you're on that disc level, there's the front of the psoas. You can see it. I like the peanut laparoscopic dissectors. You move that along. Now I put my first probe. I'm seeing the entire surface there in front of me. Put your probe in. Now take an X-ray to see where you are. So the X-ray comes in, so you know where you are in relative to the AP plate. I want to be just below, behind the ALL. And so once you've done that, you can see the entire surface is sitting here. I can see it here. And you drop it, see where you are. I want to be somewhere around there. Once you've got that, then you start putting your tube again at direct vision. You put your tubes down, you're seeing everything. I can see the surface here. I know there's no structure crossing me. There's nothing across my path. There's nothing blind here. Every single retractor goes in, you see it, you drop it. To me, I think that's critical. Your chance of having a problem is extremely low. And then obviously once you put it in, the other retractors come out. The only difference now is you are coming oblique. Yes, if you're coming in this fashion, you're coming oblique and you got to be aware of that. And again, you can see, here's the surface, all the surface. Here's the wire, this is all this, there's ALL. And you can put this retract and see the entire ALL. I'm just staring at the disc almost every single time. It's there. And that's the entire surface there. That would be my entry point. Today, I do not even use a wire. I just drop a probe right down and then put my dilators right down. Drop the probe into the disc. And then you do your annulotomy. The annulotomy for me is the most critical element of a lateral approach. You do it just behind the ALL. And you will get tremendous lordosis every single time. Put it just behind the ALL and use an 18 mm cage. I know all this discussion we've had, I disagree completely. We are not doing standalone laterals. If you're doing a standalone lateral, then you need a big cage. You're putting a screw in the back. It doesn't matter. You want lordosis. You create an 18 mm cage, you get more lordosis. And you'll pull it in, and you'll see it. You'll be getting it every time. Anyway, after this, you need this maneuver. Because you're going oblique, be very cognizant and straighten out your carb once you've gone 20% in, 20, 25% in. So once you're 20, 25% in the disc, then straighten it. Some people rush to straighten it and you slip off the ALL. You don't want to do that. And I like this ALL retractor, sort of protects you there if you want it. I prefer 2-bladed to 3-bladed. I do not like the surface. And personal preference, I hate shims. None of the problems they talked about, osteophytes, this banging, that slipping, that happening, nothing's happening here. None of that is happening here. I have nothing to put in. I'm seeing it. I can go through it as I see it. Anyway, after this, just a lateral like we always do. And I think we don't have to waste your time on that. Maybe is there anything else to show you? I don't know. Rest of it just a lateral always do. Prepare all this spaces. And every time I'm seeing the ALL. So here I am, right? So after that, it's all interbody placement. And this is just a montage of what happens. I think someone brought it up. To me, it's about release, 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 release. Mobilize, 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 mobilize. It has nothing to do with the cage. Nothing. Zero, zot, nada. I will say it 1,000,000 times. The cage is not what gave me the correction. It is the release that gave me the correction. And the cage just fills the space I created. This concept that you can stick a hyperlordotic cage, this concept you can stick an expandable cage, and you're going to get correction so fraught. You cannot. You need more than 2,500 square pounds per inch to move a disc that is sitting there. There are ligaments, muscles, tissues all around it. It's a release that's allowing you to move it, and you're filling the space with a beautiful cage. That's fine, but you have to release it. You have to see it move. And the reason we know that we're involved in developing a lot of the expandable cages, you need tremendous power to move an end plate. It doesn't move. You'll just explode it. So, but you have to release it to get it. So once you've done that, you'll see it every level. So what happens when you do that is, this is the best analogy you can give anybody. It's all ligamentotaxis. Think of a crumpled tube sock with blocks that are collapsed on it. You straighten it out, it has to line up. You actually line up. That's all we are doing. It's ligamentotaxis, lining it up. That results in great lordosis. We've looked at it between stage corrections, right? You can look at the intervening stage and see what you got. Almost 90% of our lordosis is coming from the lateral approach. And this concept, you don't get it. I've never understood that ever. We've never had that problem. And it's, in fact, coronal correction comes from the posterior as you translate, derotate, and pull the patient in a bigger scoliosis. Anyway, you can see it consistently. This happens every single time as you go along. I'll go to the posterior now. Same thing as you go along. And now you guys saw enough cases. You're converting bowel C's to bowel A's as you release the ligamentotaxis, as you pull them straight up. But there's nothing but a collapsed disc because you're reinstating back the original disc. And you're getting it from pre-op, intervening to post-op. Right? And you can get massive curves, doesn't matter. It has taken us to selective thoracolumbar fusions now. By looking at the intervening stage, you see the correction that you've got, and then all you got to do is do your posterior and line this up. And you just change the way the body behaves without a single osteotomy. So yes, so it's a lot more than just it's all being pre-sourced, controlling it and taking it, and that's like 3 years out, totally asymptomatic. My neighbor, so I know really well. in terms of where she's. So at the end of the day, I don't care. Do what you're comfortable with. The principles matter. ALIF is better at 5'1". I think going pre-psoas is better at 4'5", at least at 4'5". But it is this body and interbody manipulation and interbody splice is a spacer. Stop getting conned by some spacer doing it. You want to see what we do? Happy to come anytime. Thank you guys. Thanks a lot. Appreciate it.
Neal, fantastic talk. Like I said, every year, I'm sure we all appreciate your insights into the approach. And I agree, the release is the most important thing. You can't stuff a big cage without a proper release. You just get subsidence or end-plate injury.
Absolutely.
So, I mean, I do think that was one of the biggest points to drive home. Also, you're right. I mean, a psoas is a structure that we used to roll all the time. I think Paul brought it up. We had to shark bite incisions. But I will say sometimes it was hard to roll them. I mean, sometimes it's hard to retract it.
Usually when you see that very large psoas, the vessel is already bifurcated, and you probably should be going between the vessels. That you see on the vasculature. People come back to me, no, when you have that large, big Mickey Mouse psoas, the vessel is already bifurcated. You should not be going lateral. That's why people get in trouble. Then the lumbar vein comes around. Then go in between there.
Yeah, no, I think the depiction of the psoas that you showed was one of the best I've seen, so thank you for that. One thing is, the psoas muscle has arcuate attachments from the discs. Do you sometimes detach it, or is it always,
Not all its attachment is transverse process and posterior body.
Okay.
And they're just flimsy. They just move. It just rolls over. So if this is your psoas, you can actually get underneath it and just roll it.
And roll it
rolls.
up, yeah.
And we did that with open thoracic abdominals.
Do you always see the ureter at 5'1", and 2, have you ever had a vascular problem at 5'1" in the lateral position?
No, but we got great vascular surgeons. We got a really good vascular access guy. And so I say the problem is, it's like any ALIF, right? You're going to get the same issues any ALIF anywhere. I think, to your question,
Lateral position,
yeah.
and you have a vascular injury, I just think it's disorienting, to be a lot more difficult to repair than someone who's
Agreed. To your question, it really comes down to the vascular surgeon being comfortable doing a lateral ALIF. I agree. Luckily, we got one or two that are really, really good at that. I think that's where the crux is, who can do a lateral ALIF. I'd rather have them. I think, end of the day, I've always said, we need to get used to doing it. We either need to take it over or we need to train vascular surgeons to do ALIF right now. They're not around. Someone has to do it. We got to get comfortable doing it. And it's nice to have it. But again, if you plan it, I'll go back to all the time. The only thing you take is middle sacral. You don't have to mobilize the vessel if you plan it on the MRI. I think that's critical. We don't see that. You can plan your approach. Look at the vessel and plan it.
So, Neal, would you mind just back to the vessel planning? Can you give us, like one more time, how you determine regarding the bifurcation who might be a candidate and who not? Just if you wouldn't mind just...
Every single time you look at it, I'll go back on this. I'm not kidding you, right there. Literally look at the axial view at the level of the anterior disc. And you can see it on MRI. Here's your aorta, here's your IVC, here's psoas. This is clean lateral approach, nice area, right? You come down now to 4-5, it's splitting. Look at the split of the aorta, where it splits. This is already split at the middle of the forebody. So by the time it came to 4-5, aorta is split and IVC is split. That's more important. The aorta splitting is not good. You can still go lateral to the right common iliac if the IVC is not split. The IVC will split and sneak underneath the aorta. It sits underneath it. That's what you don't want, because even if your probe doesn't get it, your retractor will get it as you move that retractor or you expand it. So I'd say that you probably want to do an ALIF right there. And again, do the retractor, get an ALIF in there. So that's the plan. And see, that psoas is riding up. It's already gone up. That psoas is already, I've been really hard lateral. And I think that's where you got to be careful. The vessel tells me way more than psoas or iliac crest or whatever. It's a much better thing to look at. That's all, anatomically. And then like this patient, with the other one I showed you, is pretty much all three can go lateral. It's not bifurcated. See, the aorta bifurcated, but not the IVC at 5'1". See that? I can still go lateral. I'm safe. My veins on that side. I'm always going left, by the way. All the concave, convex, this, that. If you're going to do pre-psoas, you're always left. You want to be on the aortic side at all times.
Hey, Neal, let me ask you a quick question. I agree with you totally about we have to get smarter about the level we're talking about and whether we need to go pre-psoas or through the psoas. Because too long we just decided we were going to do one. And now, as you know, most of us, even prone, rotate the table and do it obliquely, especially with a two-bladed retractor. So
right.
I totally agree with that and getting to 5'1". My real question was just, you mentioned briefly about your treatment of osteoporosis and the medications. we used to leave them on before we treated them. And my endocrinologists say now you do not need to leave somebody on for 3 to 6 months. You start them at the time of surgery, and it does exactly the same thing. I wanted to know what you thought about that.
Thank you for saying that.
Okay.
Somewhere, someplace,
Yeah, I know.
somebody brought up 3 to 6 months. There is zero data on it.
It's nonsense.
The peak velocity of action of Timlos and Forteo is at 2 weeks. And you want it while you're doing your fusion. Thank you for bringing it up. I'll challenge everybody. Where did this come from? And we keep talking about it. Wait 3 months. Wait 6 months. No.
We talk about it all the time. It doesn't make any difference. And they say you want it immediately after you
Immediately.
start it because that's the most
So
effective
Stuart
time.
Silverman is a great
it's really
endocrinologist
amazing.
at UCLA. He's been
Yeah.
very strong that you don't need to, and I usually send it to them. But the other issue is Evenity. Watch it. Evenity is very easily available, and everybody's dumping them on Evenity, and that's a problem. I've had two. That actually have got pseudos on Evenity right now.
Yeah.
And I'm getting actually really upset trying to educate everybody else. No, you can't switch it because it's easy, but it's an osteoclast inhibitor.
Yeah.
Well, we spent like an hour on bone quality. But we're a little late. We're going to go to lunch, so pick up your lunch. We're going to do a working lunch here. So we're scheduled to start at 12:40, but we'll move that to like 12:50.